do whole food plant eaters need to get scans to check the health of their arteries? If so, which type of scans? And what % of the time are gastrointestinal issues anatomical as opposed to being from our lifestyle?
Baxter, you start.
I think it depends. Again, I think Joel and I, we agree that whole food plant-based label, quote unquote, is not a bulletproof guarantee. You have to get into the details, and it depends on your risk factors and other things. So for example, if a patient comes in and sees me and they say, well, I'm whole food plant-based. Okay, wonderful. Are you having any symptoms? No. And I look at their ultra-sensitive troponin, I look at the pulse score, I look at these things that have no vascular inflammation, they have a stress test that's normal, the ejection fraction is normal, et cetera. Blood pressure looks good, lipids look good. So that person doesn't need a scan. That's a whole food plant-based patient. But another whole food plant-based patient comes in and says, well, I'm having chest discomfort on a regular basis, I have an abnormal stress test, the inflammatory markers are abnormal. I'm going to ask them exactly what they're eating and start to modify what they're eating, even though they say it's whole food plant-based, because it probably needs to be some improvement there. I'm going to look at the vitamin D levels and other types of biomarkers to see what needs to be corrected there. But that person may need a scan depending on what the symptoms are. If their ejection fraction is compromised or lower than normal, then that person will need a scan. So I gave you examples of two extremes of people on whole food plant-based diet, one who wouldn't need a scan and one who would need a scan. So it all depends on their clinical scenario. Just because someone comes and says a whole food plant-based, I don't throw my thinking cap away from a medical standpoint, because some of those people need to be evaluated one way or the other. I'm still going to intervene nutritionally and lifestyle wise, but that person may need a scan on the one hand versus the other may not.
And I have a little different approach, and that's always healthy and okay. But let me just define for the audience. You can either for free in Cleveland, and Dr. Montgomery, correct me, but if the movie, the Widowmaker movie is correct, at age 50, you can get a heart calcium CT scan covered by insurance in the state of Texas. Or in my state, pay $75 and literally in about 5 seconds, get a heart calcium CT scan. And you pay out of pocket in most states, and you will get a number from 0, relatively certain jubilation moment, but not 100% jubilation, just like whole food plant-based eating is jubilant, but not 100% jubilant. Or you get a number back that could be 100, 300, 600, 1200, the degree of calcification of your heart arteries, the degree of vascular aging. So I have probably 99% of the patients in my practice have had that scan, unless they've had a bypass, a stent, a heart attack. They know they got a disease. But if you're a new patient to see me, I'm going to talk to you that for under $100, or in some cities for $0, we can define beyond just lab work and history. And I take extensive histories and extensive labs, but come back 0, let's talk about that test in 10 years. Comes back high, I'll probably never do it again because I already got my information. There is now a more advanced CT scan called CT angiography. And the real exciting thing is it's now being read by artificial intelligence. And there's a company called Clearly Health. I'm not involved. There's a company called HeartFlow that's working on that. And the ability for a cardiologist like Dr. Montgomery and I to tell a patient, 80% of the plaque in your coronary arteries and how much volume it is, but it's soft, non-calcified. We can't pick it up on these calcium CT screening scans, but it might change your life one day with a heart attack or stroke, is extremely exciting. The trade-off is it's a little more radiation and involves contrast. It's more expensive for sure. So I'm selective with these artificial intelligence CT scans. I'm pretty broad. And again, I've been doing this for decades. I love every whole food plant-based eater. I don't assume that they can skip their mammogram, their colonoscopy, their digital rectal, or what I feel is just the comparable equivalent, the heart coronary calcium CT scan. But I use it very rarely, and I very often never repeat an abnormal coronary calcium scan. I just know I got to work on this patient more.
Thank you.
From a GI perspective, when we ask what percentage of GI symptoms are anatomical, a couple come to mind, such as a hiatal hernia for heartburn, sometimes bloating when someone has they can have diverticula in the small bowel, or somebody has had an surgical anatomical change, like a gastric bypass. They can have SIBO, or from those, let's see. And those are, or if somebody had something done surgically, they can have certain things, certain types of diarrhea, sometimes diarrhea after, you have your gallbladder removed. I'm trying to think of other reasons why, other anatomical reasons for people to have GI symptoms, but those are sort of the common ones that come to my mind. Can you kind of think of any more, Dr. Pasricha? Those are the big ones that would cause you to have sort of GI symptoms. But I also think, in addition to sort of you having something anatomical, it is still dietary in a lot of ways to sort of change those things. Sometimes I'll have a patient that is on a perfect diet, that is not have excess weight, that has been on not only a perfect diet, not only smaller meals, not only avoiding trigger foods, on a PPI, and they still have, terrible heartburn. They still have terrible elevated levels of acidity when we do a pH impedance study. And these people maybe would need to have sort of a surgery called disinfundiplication, or sometimes it could be done endoscopically now to treat their hiatal hernia as a cause of their acid reflux. So just like Dr. Kahn and Dr. Montgomery said, there are instances in which a patient can be on this sort of perfect diet and still have some symptoms. I don't think it's extremely common that I have a patient that is sort of normal, normal weight and on a perfect diet and sort of continues to have symptoms with a hernia, but it can happen.
Thank you.
Yeah, I agree with you, Dr. Laster, that most of the GI illnesses and conditions I see are probably lifestyle related. You mentioned the main ones that are anatomic: the hernias, the scarring and narrowing, usually from a surgery, some stenosis of some sort. But most of the time it's from some sort of lifestyle issue that's going on. But I agree that, when people are coming in with symptoms like abdominal pain or, change in bowel habits, we still need to do the workup to make sure, because even though things like a blockage or a cancer, these type of things are very rare, we still need to make sure that it's not that, so we can treat it appropriately and not let something go missing for a long period. So if somebody is coming in with a lot of upper abdominal pain, we kind of need to look: is there an ulcer? Is there a bacterial infection? Is there an anatomic blockage or hiatal hernia? So we don't know until we do the workup. We are lucky that we can do endoscopies and we can actually see inside. So it is important that, patients take advantage of the tools that we do have to look and see what's going on. Once we make sure there's nothing else, then we can always focus on making lifestyle dietary changes.
And I just want to add one comment, because I think there's a common thread to the questions about specialties. And I mean, we all agree that, everybody who proclaims a perfect diet, needs to have an evaluation. And it's not, at least for myself, and maybe my panelists feel the same way, I don't think the perfect diet is not perfect. I think the proclamation of a perfect diet is not perfect. So people come in saying, I'm on a whole food plant-based diet, and then you start talking as well. I eat, fried chicken every, third Sunday or something. I don't know, so people will give themselves a label that I'm eating a whole food plant-based diet, or I'm eating the perfect diet or whatever. But, that's a proclamation of a perfect diet. It's not by evidence of perfect diet. So, it's tricky in our area when we're trying to straddle both lines, practice sort of on a natural, holistic, lifestyle fashion, and also do the traditional medical things. Because if someone says I'm on a perfect diet, and you say, okay, great, you don't need a workup, and they have a cardiac arrest, then it's a problem, or they have some massive GI problem, it's a problem. So that's the tricky part in this. So I want the audience to understand that it's not, at least for me, I'm not saying an ideal diet is not ideal, but when someone comes in and says I'm on the ideal diet, I need to examine that more carefully. And if they're having symptoms that contradicts that they're on an ideal diet, then I need to evaluate that, because I'm responsible for that.
Agreed. Just because you're on an ideal diet doesn't mean you don't. I'll have patients that say, well, I don't need to have a colonoscopy because I don't eat meat and I have no family history. Yes, you still need a colonoscopy. That's the gold standard for testing for colon, to check for colon cancer. And we can remove polyps before they become a cancer. So not eating meat, that's great. I don't want you to eat meat, because the opposite of that is I take out 8 polyps from a patient. As soon as they wake up, the common question is, oh my God, what do I need to do to make this not happen again? And as soon as I say, reduce, processed meat and red meat, everybody goes, okay, everything but that. So you still need a colonoscopy, even if you don't eat bacon and sausage and steak every day of your life.